Good evening, everyone, and welcome to our webinar this evening from Benenden Hospital. Happy New Year to you all. And this is our first webinar of 2024, and we're covering a very interesting topic tonight on knee replacement surgery with robotic surgical assistance. My name is Phil, and I'm your host this evening. I'm joined by our expert presenter, Mr. Alex Chipperfield, consultant orthopaedic surgeon. Now, if you haven't attended one of these webinars before, the format is as follows. The presentation will last around 20 to 25 minutes, and this will be followed by a question and answer session. If you'd like to ask a question during or after the presentation, you can do so by using the Q&A icon on the bottom of your screen. You can do this anonymously, or you can give your name, but we should let you know that if you do give your name, this session is being recorded for archiving. If you would like to book your consultation following the session, we'll provide contact details at the end of the webinar. So without further ado, I will hand over to Mr. Alex Chipperfield.
Thanks, Phil. Thanks very much. Good evening, everyone. My name's Alex Chipperfield. I'm one of the consultant orthopaedic surgeons here, and I'll be talking about knee replacement surgery using robotic assistance. Included in this session, so I'll speak a little bit about myself and then the hospital here that we work in. I'll talk in broad details about the symptoms and signs and treatments for arthritis of the knee and knee replacement surgery in a bit more detail. I'll then go on to discuss robotic assistant knee replacement and what that brings to the field and how that can improve matters. And then I'll be around to answer your questions afterwards. So to start with me, so I've been a consultant orthopaedic surgeon for the last 13, 14 years now. I work here in Benenden as well as other hospitals in Kent. I've been here since 2012, and I specialise in hip and knee surgery, predominantly hip and knee replacement surgery. I'm not the only person who works here at Benenden. There are half a dozen of us here who specialise in knee replacement and knee surgery, and their names and pictures are all up on the screen for you to see here. Knee arthritis, what are the early signs and symptoms? Well, there's a couple of pictures here. The one on the left shows what a normal knee looks like, with lovely smooth surfaces on the ends of the bone, and those smooth surfaces normally glide freely over each other as your knee moves. What happens when you get arthritis is that lovely smooth coating starts to fragment, break away and wear down, and you end up with rough, exposed, painful, bony surfaces that will grate and grind against each other and lead to pain and stiffness and feelings of clicking and grinding and swelling and inflammation around the knee. In the early stages, those symptoms can be measured with what we call conservative measures. So painkillers, physiotherapy, sometimes injections, that kind of thing. There comes a point, though, that those symptoms will increase, things will deteriorate, and you'll get to the point where you develop the later symptoms. So you get pain not only when you're doing things, but pain when you're not doing things as well. So you can get woken up at night by pain in the knee. The stiffness can limit your physical activity, and it can have an impact on what you do or can't do. You can get deformities of the knee, where the knee will either bow or become more knock-kneed or bandy-legged, depending on which part of the knee wears out more rapidly. All of these things lead to an unhappy, painful knee that restricts your quality of life and limits your daily activities. And when you get to that stage, it's time to start thinking about treatments. There are many different treatments for arthritis of the knee or other joints, and they tend to depend on the severity of the symptoms or the impact that it's having on your life. Generally, with treating any condition like this, you start small and build yourself up. So the first kind of treatment options that you try will be non-surgical, so not having an operation. Looking at physiotherapy to build up the strength and the support around your knee. Activity modification. Now, what most people interpret that as saying, well, you can't do exercise or you can't do load-bearing exercise with an arthritic knee. Actually, quite often it's the opposite. Exercise, movement, keeping everything around your knee as strong and supportive as possible can help support a failing joint and actually prolong the life of a worn out knee. Simple painkillers, analgesia, so over-the-counter medications that you can get, such as paracetamol or codeine, they work very well as painkillers. There are also anti-inflammatory type medications like ibuprofen and Voltarol, which can also help calm down inflammatory change around the knee. These can be given as tablets or gels that you can rub on that will help. Some people find that strapping the knee or having a brace can support things and take a bit of pressure off, and that can buy you a bit of time and help. There are also injections that you can have into your knee. Typically, there are two main types of injections. Either steroid injections, which are very powerful anti-inflammatory injections that can help calm down a big, swollen, angry, inflamed knee. The other type of injections that you can have are things called hyaluronic acid injections, which are much more of a lubricant, and the theory of that is to coat the rough edges and allow the inside of the knee to again glide more freely. And all these non-surgical activities, either in isolation or combination, can help people live with a worn out knee for many, many years quite happily. Eventually, though, you may well get to the stage where those measures fail or stop working, and then you would consider surgery. There are several different operations that you can do depending on the severity of the disease or the particular distribution of the arthritis inside your knee. There are keyhole surgery operations that you can do. You can break the bones and realign them. You can try and, there's some experimental work about replacing lost cartilage to try and increase the cushioning in the knee. But ultimately, the only definitive long-term surgical treatment for an arthritic knee that fails all other methods is a knee replacement. There are lots of different types and brands of knee replacements. It's a very common operation. There are about 100,000 performed in the UK every year, and the results are overwhelmingly good. The average age for someone to have their knee replaced in England is 69, but that age is getting younger as people are becoming more demanding, and more active lifestyles have led to knees sometimes wearing out a bit more rapidly than they would have done previously. There's a slight bias towards ladies having their knees replaced over men. It's about 55-45. That may well be just because women live a little bit longer. Another factor may be that women are more likely to have injuries around their knee, especially cruciate ligament injuries, due to the anatomy, and that can lead to wearing out of the knee in later life. As I've said, it's a good, reliable operation. The overwhelming majority of people who have knee replacements, more than 9 out of 10, are very happy with the results. And it is an incredibly long-lasting, hard-wearing implant. The aims of knee replacement surgery are to decrease your pain, and as a consequence of that, to increase your mobility and restore the function to your knee. Balancing your knee, correcting any deformity or major loss of movement is part and parcel of that. There are, as I've said, the age of knee replacement surgery is getting younger, and with higher demand patients comes the expectation or the the wish to get back to higher functioning, higher impact sporting activities and more demanding high impact jobs. And that can be a challenge for surgeons and for implants. So with these greater expectations, the drive is always to try and improve the outcome measures and the functional results following this kind of surgery. The kind of knee replacement we use here, like I said, there are many different brands. There are lots of different manufacturers of knee replacements, and they all have different brands. With the one that we tend to use the most here is something called the Vanguard knee replacement, which is shown on the slide there. That's manufactured by a company called Zimmer Biomet. And the reason we use that is because it has the best combination of being a proven, long-lasting, hard-wearing implant that also performs well on a daily basis. The ODEP rating, the Orthopaedic Devices rating, gives you an idea of how long these things last. And 15A is the best rating that you can get. The Vanguard knee replacement tends to be fixed into the bone by using bone cement, which is a kind of grout that holds the metal parts of the knee replacement in place in the bone. And that this implant can be used with or without a patella resurfacing, which is when you replace the undersurface of the kneecap as well. Surgeons are divided as to whether or not they routinely resurface the patella. There are some who never do. There are others that always do. I tend to replace the patella maybe about 8 out of 10 times. Generally, when I see a kneecap that has any visible signs of wear when I'm doing the operation, then I will replace that as part and parcel of the surgery as well. The operation itself takes around an hour and a half to do, and most people are in hospital for 1 or 2 nights following their surgery. Initially, after the operation, you'll have a big bandage on your knee, which gets taken down after the first night, and then we start getting you up and about and getting things moving. Your knee will be painful. It will be stiff and tight and swollen after the operation, and dealing with that pain, dealing with that swelling, is the biggest challenge in the early days as far as your recovery goes. You will need pain medications. A lot of people feel huge amounts of benefit from ice therapy and cold to help calm down the swelling, and the nursing teams and the physiotherapy teams will support your mobilization in the first couple of days while you're in hospital. You will be discharged home normally on, like I said, on day 2 or day 1 if you're really flying following the operation. When you go home, you'll be discharged on a pair of crutches and on the necessary pain medications. You'll be supported in the community by further visits to the physiotherapist, and the first month or so is all about decreasing the pain, decreasing the swelling, increasing your movement and function as time goes by. Normally, by the time you come back again to see me after about 6 weeks following your surgery, most people are walking independently at that stage. Some people are using a single crutch when they're indoors. Their range of movement is improving and the dust is settling from the surgery. But that first few weeks is tough, is hard work. Once you get through that, the results really start to pay off and you notice a big change. The recovery itself, though, from this kind of operation does take weeks and months to get through. I tell people not to make any big plans for the first 3 months because you may not feel ready to be doing most things until that stage. But on the whole, if you do what you're told, if you grit your teeth and get through those early stages, the overwhelming majority, it's a great operation that works very well. Potential risks. I'm not trying to put you off, but there are a few things that are potential hazards of the surgery, potential pitfalls. And on this slide, what we've done here is we've divided those up to things that can occur during the operation, things that can occur early on during your recovery, and then later risks of surgery. The focus of this talk is about robotic surgery. And one of the reasons why robotic surgery has come to the fore is because knee replacement isn't perfect. Like I said, you can see there are things that can happen during or after the operation. And the aim with the robotic surgery is to minimize the risks of some of these things from occurring. So if we look at the injuries that can occur during surgery, one of the advantages of robotic surgery is that there's less of a chance of injury to the ligaments or tendons that support the knee. During the recovery stage, there's talk about stiffness and swelling and limping. And again, less trauma to the soft tissues around the knee when you're having the surgery theoretically should lead to less in the way of stiffness and swelling in the immediate post-operative period. Don't get me wrong, it will still be sore, there is still swelling, but the theory is that with a robotic assistant, that will be less. If we look at the late complications that can arise from knee replacement, things like fracture, broken bones, things like dislocation, things like implant failure due to the implants wearing out, revision surgery in general. If you can find a way to place that knee replacement as accurately as possible, then theoretically those longer term complications or problems can be less. And that's the aim from the robotic surgery. So the aim is to minimize the impact of the surgery, to minimize the risk, and to improve the early and therefore later on outcomes from the operation. This is a picture. This is ROSA, the robotic surgical assistant. This is the machine that we use here at Benenden to aid us with the surgery. This is actually only half of it. So the ROSA system itself consists of the robotic arm, which you can see on the slide there. There's also a camera system, a camera array that is in the operating theatre as well. And it's these two machines working in harmony with each other that help me during the operation to improve the outcomes of your surgery. So, like I've said, the aim, the perceived benefits of the ROSA system or the robotic system in general is to reduce the likelihood of the soft tissue injury around your knee, or rather limit the damage to the soft tissues around your knee. There are studies that associate robotic surgery with less pain. Like I said, it will still be a painful thing to go through in the early stages. So don't expect to have no pain even with a robotic operation. The potential for getting out of hospital more quickly, getting back to activities more quickly, and a better functioning knee afterwards are all derived from the fact that if you have a more accurate operation done with less trauma around your knee, then you should bounce back more quickly. Just going to have a drink, sorry. How does the ROSA knee system work? There's a picture of me there staring intently into space. What I'm actually doing there is I'm looking at the screen. There's one screen visible on the robotic arm, it's in the picture there, but then there's another screen on the camera array, which I'm looking at. So the system works with, there are sensors, and those are those blue things that you can see that are attached to the bone model that I'm working on there. Those are sensors that are attached to the bone during the operation. Those are picked up by the camera system, and that then is the position of your knee and the position of the surgical instruments are then calculated by the system to allow the robotic arm to make tiny adjustments in the movements of the arm when you're doing the operation. So a lot of people worry, a lot of people think that the robotic arm is actually doing the operation instead of me. That's not the case. The robot ROSA is basically a tool that I use when I'm doing your operation. It allows me to make more precise cuts in the bone. The way it does that is by the robot, like I said, knowing exactly where the position to hold the cutting blocks in, so that then I can use that to make the cuts in the bone myself. So it's me doing the operation at all times. The robot arm does nothing unless I tell it to, and all it does is move and position everything so that I can do the surgery more effectively and more accurately. Essentially, with ROSA, or any robotic surgery, there are two parts to two advantages to using a robotic assistant. One is, like I've mentioned, the accuracy of the cuts and the accuracy of the placement of the implant. But there's another part which ROSA has evolved from, which is the planning of the surgery and what we call navigation. In the old days, we used to use navigation programs which used those sensors and used those cameras in order to plan the surgery in real time while we're doing it. And what the navigation side of the robotic surgery does is it gives you three-dimensional, real-time information about the amount of deformity in the knee, about the movement, and about the balance of the soft tissues. And if you're accurately mapping out all of those things at the start of the surgery, and then at every single intervention or every single cut you make whilst you're doing the surgery, you can then reassess that during and after the operation. So that planning side of it, as well as the execution of the plan, allows you to, in real time, adapt, modify, and tailor the surgery precisely to the deformity or to the particular pattern of arthritis that you have yourself. And that's the big advantage that I find with the robotic surgery, is the planning and real-time data capture that you have less of when you're not using a robot to perform a knee replacement. I showed you half a dozen of us who all specialize in knee replacement surgery. All of us will be offering this service down the line. Obviously, it takes a bit of time to get trained up and to make sure that you're safe and comfortable and confident with the system. Currently, as of January, there are 3 of us that have passed that final hurdle. Over the next few months, more of us will come on board with that as well. Is the system right for me? There are a few situations where robotic surgery isn't the right thing to do. And interestingly, the biggest thing that I find, the biggest reason why people might not be suitable for a robotic knee replacement, is nothing to do with their knee or how their knee is. It's to do with the rest of them. And most importantly, it's to do with their hip joint. As I've said, part of the robotic process is that real-time data gathering, that planning of that, an assessment of that movement of your leg during the surgery. In order to accurately do that, you have to have a hip joint that moves freely, normally, and reliably. And so people who have very bad arthritis of their hip, or who've had a hip replacement, or who've got a condition that means that their hip doesn't move in a normal way or in a reproducible way, you tend to struggle gathering enough information to reliably use the robot when you're doing this surgery. So I would say the #1 reason for people not being suitable for a robotic surgery of the knee would be for a pathology around their hip that prevents that gathering of that data. Obviously, everyone is different, and that discussion as to whether or not you'd be suitable for surgery is something suitable for robotic surgery is something that we talk about at the consultation when you come along to talk about this with me or any of my colleagues. The company have provided this video, which just shows a little bit of movement of the robotic arm in more detail. It's a 90-second video, which I'll just play here for you, just so it'll just talk about, you'll see everything moving, which will give you an idea of what things look like, and also give you the idea of what the robot does and what the surgeon does as well. So I'll just click and press play for that, and I'll stop talking for 90 seconds.
ROSA Knee is a robotic surgical assistant for total knee replacement. Your surgeon is specially trained to use the robot. ROSA Knee does not operate on its own. Your surgeon is in the operating room the entire time and making decisions throughout your surgery. Your surgeon creates a plan for your surgery based on your unique anatomy. The robot helps to ensure the plan is executed as intended. ROSA Knee uses a camera and optical trackers to know where your leg is in space. If your leg moves, the robot can tell and adjusts accordingly. ROSA Knee provides your surgeon with data about your knee. This helps to personalize your surgery based on your unique anatomy.
There you go. So hopefully that gives you an idea of how things move and how the robot moves during the operation. Get rid of that. A lot of people, the difficult decision, apart from whether or not to have a robotic assisted knee replacement, is whether or not to have a knee replacement in general. And there are lots of different ways that you can come to that decision. The best way is to have a conversation with me or someone like me who can look at your particular set of symptoms and look at your level of function and talk about whether or not it would be a realistic thing to do, whether you would benefit from a knee replacement, or whether it's either too early or, God forbid, too late to think about that operation. The website that is at the bottom there, the Patient Decision Support Tool, is a very useful thing. That allows you to it uses data that is provided by the National Joint Registry, which keeps monitors every single implant that has been put in this country over the last 20 years. So it's a huge data set. And what it does is it allows you to put in your own symptoms, level of function, and it can tell you the level of improvement and the level of functional gain that you'd expect to see following a knee replacement. So that's a very useful tool. The other thing to think about is choosing your hospital and choosing your surgeon. And there are lots of different ways to do that. You can look at the joint registry to look at a surgeon's profile to see how many of these operations they do on a regular basis. You can also look at review sites such as Doctify to have an idea of the kind of feedback that we as surgeons get from patients, and also the kind of feedback that hospitals get. So I would recommend that before you think about, if you are thinking about knee replacement surgery, number one, I would go through that decision tool, because I think that's useful. And I would also look around for a clean, high volume hospital that has low revision rates and low infection rates. And I would look for a surgeon that has good reviews, but also a surgeon who does this kind of operation day in, day out. If you're kind of surgeon who is doing hundreds and hundreds of knee replacements every year, or hundreds and hundreds of joint replacements every year. That's what you want in your surgeon. You don't want someone who does one every now and again, who does half a dozen a year or so. You want someone who does this for a living, if you see what I mean. That's all that I have on the presentation here. We'll now is the time for the Q&A session. Phil, there are a few questions here. Shall I just go through them from top to bottom? We've got some on the screens here. I can start answering them, and we can see where we go.
Yeah, of course. So first question we have is from Kay, and she says, I was told I needed a patient-specific knee replacement due to a pin in the femur. I would like to know about any problems if the pin is removed after about 40 years. Also, if it isn't removed, how good are patient-specific replacements?
Okay. Difficult to tell you about your exact case because obviously, you know, I'm only speaking in general terms. What I don't know is where in the femur the pin is, whether, you know, and that kind of situation. Essentially, though, in the old days, before navigation or robotic surgery, when one of the first things that you do in order to try and make your knee replacement as accurate as possible is you put a rod that goes inside the thigh bone to give you the axis of the thigh bone, and all of your measurements are taken from that rod. If you have something inside your thigh bone that it stops you putting that rod in, then that can make life difficult. And so that in that kind of situation, you would use a navigation system or a robotic system, such as ROSA, to negate the need to put a rod down inside the femur. If the pin in the femur is simply obstructing the surgical technique, then there are ways to modify your surgical technique to get around it. If that rod is so prominent that it means that you can't put a knee replacement in because the metal's in the way, then you might have to remove that first. Having an implant in your leg for 40 years and then trying to remove it is not a benign thing to do to someone, and it can, you know, it has its own unique set of circumstances. So I think in your case, what I would suggest is that you come along, we look at your x-rays, we look at your knee, and we talk about the feasibility of doing the surgery. If we can do the surgery without removing the rod, then ROSA would be ideal for that. If you'd have to remove the rod first, then we'll talk about that as well. That's about as good as I can give you at the moment without knowing more about your case, but hopefully that helps.
Okay. Next question is, have you come across plasma injections as a treatment for a knee problem?
Yes, I have. So I spoke about two different types of injections. I spoke about the steroid injection and the hyaluronic acid injection. The reason I didn't speak about the other kind of injections, which is things called PRP or platelet-rich plasma, is because unlike the steroid or the hyaluronic acid, there isn't strong scientific evidence that a PRP or a plasma injection has any benefit in the medium to long term when it comes to either halting or reversing the arthritic process inside someone's knee. So plasma injections are out there. There are people who are huge advocates of that, but I'm afraid at the moment there isn't enough objective scientific evidence for me to recommend that you spend your hard-earned money on an experimental treatment. There we go.
Okay, thanks. Tim asks, would I be able to jog on a treadmill after recovering from knee replacement surgery?
Yes, given time. The first thing that the early stages of the recovery from a knee replacement are all about building up the strength and the movement in your knee. If you're the kind of person that goes to a gym and has a treadmill, then you may well also be the kind of person that has an indoor bike or a static bike. Most people find that in the early stages, they get more benefit from being on a bike than on a treadmill as regards to improving the movement and strength around your knee. Once everything is settled in, once the recovery phase is over following a knee replacement, then I have no issues with people walking, running, long distances, either indoors or outdoors, whatever they want. If you're talking about using a treadmill as a recovery tool from the surgery, there are probably other things that are a bit better than a treadmill, such as a bike. But in the longer term, once things have settled, I had no objections to that at all.
Okay, our next question comes from Sarah, who asks, are the replacement joints still made mostly of metal?
Yes, is the short answer. The longer answer to that is that the knee replacements on the whole are made of a combination of metal and plastic. And that gives the combination of something that is hard wearing and strong enough to function as a knee for many decades, but also soft enough to give some cushioning to allow more movements. There have been some advances in the different types of metal, and there are some manufacturers that ceramicize their metal or coat their metal in other substances to try and make them even smoother and longer lasting and hard wearing. There has been some research in developing ceramic knee replacements, because ceramic hip replacements are a fantastic innovation. There hasn't been the same kind of innovation when it comes to knee replacements. Ceramic knee replacements are yet to be proven. Metal knee replacements are the mainstay of treatment, but there are, like I say, there are different coatings to that metal that can theoretically increase the lifespan of the implant.
Okay, thanks. Next question comes from Andrew, who says, is it okay to elect for knee replacement because I'm finding hill walking and other outdoor activities increasingly difficult and painful as opposed to impossible? I have a damaged, displaced meniscus leading to bone on the medial side.
As I mentioned earlier, people's demands, people's expectations following knee replacements are increasing all the time, and people want to be able to get back to their normal activities such as hill walking and being outdoors, that kind of thing, and the decision as to when do you proceed to knee replacement, when is enough enough, that decision is a very difficult one to make. You're struggling to do that, but you still can do that kind of thing. In the old days, people used to wait until they couldn't do that or could barely walk across the room before they decided to go down the surgical route. And part of that was that knee replacements tended not to last too long, or the early versions of knee replacements were mechanically not quite as refined as they are today. The decision that you make as to whether or not it's time to have that operation is the simple question is whether or not you are prepared to live with your knee the way it is. Everyone will have a different level of activity or lack of that they're happy with before they proceed with surgery. I would, have a conversation with your surgeon as to what your expectations are. What I wouldn't want you to do is to be promised something that can't be delivered by a knee replacement. But if you're realistic about your outcomes, if you've got bone-on-bone arthritis, then it certainly would be an option. As to whether or not it's the right time for you, that's a discussion to have with your surgeon. Next one.
Okay, moving on to a question. This person asks, when is a good time to think about returning to a manual job? Would it be best to wait 3 months?
Yes. I tell people, especially people who have a manual job, that you will need time to recover from this. It is a big operation, regardless of whether or not you use a robot. You need time to heal and recover. And what you need in that time is to be focused. You need to be selfish. You need to be focusing on yourself. You need to be be dedicated to your recovery. And what you don't need is people with unrealistic expectations on you about when you're going to get back to work. If you tell people that you're going to be off for 6 weeks, work will expect you back at 6 weeks, and you'll be putting yourself under a lot of pressure to do that, and you may not feel ready or right to do it, especially with a manual job. If your job involves a lot of lifting, carrying, or difficult or atypical movements, then you are going to need that time to recover and heal. So I tell people, be very open from the outset. Say, I will see you in 3 months. And even then, it may well be that you'll need to gradually return to work, either on partial duties or lighter duties, until you build up the full amount of strength and confidence in your knee.
Okay, thanks. Next question comes from Linda. Do you perform partial knee replacement?
Yes, I do, and nearly all of us who perform knee replacements here also perform partial knee replacements. That service isn't currently offered with the ROSA robotic system, but it is something that hopefully within the next year to 18 months they will be introducing. So yes, we do it. We use conventional methods to perform those operations, and both myself and lots of my colleagues here perform that. So yes, it is an option, but not with ROSA just yet.
Okay, thanks. This person asks, I've had injections in both knees and hips. Suddenly much worse, so looking at surgery. I've subsequently been told that I now need to wait 6 months before surgery. Is this right?
I presume what they're talking about there is the time between having an injection in your joint and having a joint replacement afterwards. Steroid injections, so one of the type of injections that you can have into joints, there is some scientific evidence that if you have an operation rapidly following a steroid injection, there is a slightly increased chance of you developing an infection following the joint replacement. That evidence seems to suggest that the safe window is sometime around 6 months onwards. Different surgeons will feel comfortable with different levels of risk. There are some surgeons who say if it's within 3 months of an injection, they're not happy, but any time after that is fine. I think 6 months as a minimum after a steroid injection, I think is a sensible thing to do to minimize the potential for infection. An infection in a joint replacement is a catastrophic event, and anything that you can do to lower the risk or minimize it, then I would suggest that you follow that. If you've had a different kind of injection, such as a hyaluronic acid injection, then there's less evidence that can increase the risk. So that might be something that you need to discuss with your surgeon in more detail to get a bit of clarification.
Okay, thank you. Moving on, is there a difference in the length of time of surgery for ROSA and non-ROSA surgery?
Yes, there is. We've been focusing on the good things about robotic surgery, but there are some bad things as well, or some things that are different. And one of the things that you consistently see is that robotic surgery, it does add time to your operation. Typically, most knee replacement operations take about an hour or so to do. Using the robotic surgery, there are extra steps in the operation, whether it's the placement of the sensors, whether it's the gathering of the data and the planning and the processing of that, and the movement of the arm, which is slower than a human arm, as you could see from the video there. All of these things do add up, and so typically it would add about somewhere between 20 minutes and half an hour to the length of your operation.
Okay, thank you. Robert asks, I had my left knee replaced in 2021. Having the staples out was the most painful part afterwards. Could stitches be used instead?
Yes. So there are two ways that you can close a wound following surgery. One is with staples or surgical clips. The other is with stitches. And typically the stitches tend to be a dissolving stitch that sits just under the surface of the skin. The advantage of a dissolving stitch is that it doesn't have to be removed. Removal of surgical clips is normally a relatively painless thing to do, but some people struggle. Some people have, every now and again, you hear horror stories from people who've, with nurses or other people removing those clips who have really struggled to do that. So typically, I tend to try and avoid using staples in knee wounds if I possibly can. The exception to that, though, is that if the skin over the knee is very thin, very delicate, then sometimes it's not thick enough or strong enough to support a dissolving stitch, in which case I do have to use clips. I find that probably about a quarter of the knee replacements that I do end up having staples. If you were to come along and have your knee replaced by me and you tell me the story of how horrible you found the clips being removed, I would do everything that I possibly could not to use them. But if your skin is incredibly weak and friable, then we might have to do that. But the one thing that we could change would be the person removing those clips. So instead of going where you had the bad experience last time, I'd be more than happy to do that myself or have one of the nurses here do that instead. So either way, we should make things a bit more pleasant.
Okay, thanks. This person asks, I was due to have a knee operation last February. I was scared and did not go ahead. I've trained in the gym and I'm coping. Can a knee become too damaged to have a knee replacement?
Theoretically, it could. Realistically, in the modern world, it doesn't. There are two things that you think about. One is, will everything wear away so much? Will there be such a big deformity that a standard conventional knee replacement is no longer sufficient? That can happen very rarely in people who haven't, people who've been, for whatever reason, avoiding coming for an operation. Every now and again, you end up needing to use a slightly more advanced kind of knee replacement. One of the ones that you might typically use in a revision operation or a redo operation, where there's often quite a lot of bone loss, you can use them in a primary situation if the bones have eroded dramatically. It's really rare for someone to go that long this day and age in the modern environment. The other part of the equation is the muscles and the joint, the ligaments and tendons around the knee replacement. If you leave things for a very long period of time, knees can stiffen and can weaken. You can still do the operation, but then you rely on those stiff, weak muscles and tendons to move the knee afterwards. So people who leave things too long from that point of view can often struggle with their recovery, or it can take longer to recover because they're starting from a much lower base point. So you working hard in the gym to keep your muscles as strong and supportive as possible, number one, it can give you a bit of a helping hand and help delay the surgery, which is what it sounds like with you. But secondly, if you do come to having a knee replacement in the future, then you will be at an advantage by having those muscles around your knee as good as they can be. That will make your recovery a lot more quick.
Okay, thank you. Dawn asks, is the replacement joint hyperflex that will allow me to continue with yoga?
All knee replacements are artificial joints made of metal and plastic, and none of them perform as well as a completely normal knee that doesn't have any disease in. The fine movements that involve pivoting and twisting, knee replacements will not do. The other thing that most people find is that very, very deep flexion of the knee. So getting to the stage where you are sitting on your heel. So you're bending your knee so far back that you're sitting on your heels. That is very rare to see someone who's had a knee replacement be able to do that. Most modern functioning knee replacements, with a good result, you will get to around 120 or 130 degrees of flexion. But to get to the level where you're sitting on your heels, you won't achieve that with a knee replacement. And to be perfectly honest, if you can do that, you probably shouldn't be thinking about a knee replacement in the first place. If you've got that kind of movement, then it would imply that the disease is not at the advanced level where you would benefit from a knee replacement anyway.
Okay. Next question is, I've been diagnosed with osteoporosis. Would this affect the clinical decision to do a knee replacement?
No. Although people are getting younger for their surgery, it is still an operation that you do later in life. In there, people, average age is late 60s, early 70s, and hand in hand with getting older, you get other problems as well. So we're used to operating on people who have multiple medical problems, and as long as they're stable and controllable, then we can perform the joint replacement surgery. We're also used to operating on people whose bones are a little bit weaker as part of the aging process and osteoporosis. You do have to take more care during the surgery. You also have to, I mentioned the fact that this knee replacement is cemented, and one of the advantages of using a cemented implant over an uncemented implant is that it can help restore a bit of strength or solidity to bones that might otherwise be weaker. So no, having osteoporosis wouldn't normally stop you from having a knee replacement. In fact, a lot of people who have knee replacements will have a degree of osteoporosis as just part and parcel of being slightly older.
Okay, thanks. The next question is, I'm 43. Am I too young to consider surgery?
No. So in my book, age doesn't matter. What matters is the level of function of your knee, the symptoms that you're getting, and whether or not that's having a severe enough impact on your life to be thinking about surgery. I've done knee replacements on people in their 20s and people in their 100s and everywhere in between. Essentially, what it boils down to is whether or not you are ready for that surgery. At 43, you're not too young, unfortunately. But the younger you are when you have this kind of operation, there are certain elements of this operation that are become more relevant to you. So the fact that a knee replacement is incredibly long-lasting and hard-wearing and lasts decades is a good thing. But if you're planning on living another 40 years, the chances are that it may well get to the point where your knee replacement wears out before you die. So the risk of the implant wearing out in your lifetime is higher the younger you are when you have an operation. The alternative is to wait until you can guarantee that it's going to last you the rest of your life, which is fine, but what do you do for the next 20 years until you get to that age? So really, it's all about balancing the pros and cons of this surgery. Like I mentioned about the decision-making tool earlier in the talk, that will give you, if you type in your age, your height, your weight, your activities, and your symptoms, that will give you a very realistic idea of how long that knee replacement is expected to last. Age is one factor, but it wouldn't be the only determinant as to whether or not you have your surgery.
Okay. This person asks, do you use general anesthetic or spinal injection?
Both. Typically, most people who have knee replacements have what's called a spinal anesthetic, which is where you have an injection into your back, which will put your legs to sleep. The good thing about that is that it stops you from feeling anything during the surgery, but it also gives you pain relief after the operation as well, which is quite important in the early stages because it's painful. On top of a spinal anaesthetic, most people elect to have some other form of anaesthetic as well, normally what we call heavy sedation. So most people who have their knee replaced will be asleep from the waist down with the spinal anaesthetic. They'll also have sedation on board as well, which means that they won't hear, see, or feel anything about what's going on. You'll be asleep or unaware of what's happening. If you want to be completely wide awake, you can. You're not going to see anything during the operation either way, because there will be drapes masking the knee from the rest of you. So you don't get to see anything, unfortunately. If you want to be awake, you can be. If you don't, you won't be. Sometimes, for many different reasons, a spinal anaesthetic might not work or take, in which case you will have a general anaesthetic where you go fully to sleep. Either way, you won't know what's going on.
Thank you. Okay, moving on to the next question. Are all knee joints standard, or can a joint be made to measure depending on the circumstances? For example, leg length.
So there are custom built knee replacements that can be tailored, based on scans of your knee beforehand. They can be manufactured in order to precisely fit your knee. They are prohibitively expensive and overwhelming number of cases unnecessary. Knee replacements don't just come in one size. They don't just come in left or right, or small, medium, or large. Each of the components that makes up your knee replacement, so the femoral component, the tibial component, the patella, if you're having that, the plastic that goes in between, each of those comes in multiple different sizes of 1 millimeter difference. And so when you're having a knee replacement, and again, when you're planning that with the ROSA or with any other system, and when you're doing the surgery yourself, everything is being measured. So we have a selection of 25 different femoral components, 25 different tibial components, 25 different polys at all different thicknesses, 25 different patellas. All of these things are available, and the implant that you receive is tailored to you in real time during that surgery, but it is tailored to you by choosing the best implant that we have available, building one for you specifically. Like I said, time consuming and overwhelmingly unnecessary, tends to be used more as a sales technique rather than an actual benefit to you in the longer term.
Okay, thank you. Unfortunately, we've run out of time for any further questions. I'm sorry if we didn't get around to answering yours, but if you've provided your name, we will answer yours via email. Mr. Chipperfield, can you just move to the final slide, please? So as you can see on screen, we are offering an exclusive attendee offer, and you receive 50% off your initial consultation as a thank you for registering for this webinar. You will receive a callback from your dedicated private patient advisor. You will have an email tomorrow with the webinar recording, some treatment information and pricing, and updates on news and future events. If you'd like to discuss or book your consultation, our private patients team can take your call tonight until 8 p.m. or between 8 a.m. and 6 p.m. Monday to Friday, using the number listed to the right of your screen there. After this webinar, you will receive a survey, and we'd very much appreciate you filling out that survey. Your feedback obviously helps us to improve future events. Our next webinar is on hip replacement surgery, and you can sign up to that via our website. All that remains for me to say is, on behalf of the team here at Benenden Hospital, I'd like to say thank you for joining us today, and we hope to hear from you very soon. Thank you and goodbye.